Pleasure to be here again for the next installment of our lecture series on the beauty of the brain. And it's my pleasure to introduce John Sommers-Flanagan. And you'll notice an interesting trend from lecture to lecture. We talked about insects last time, at least in part, and now we're switching to humans. And that's the kind of things that happen when you get into neuroscience. I mean, it really touches on everything, and it's relevant at multiple levels. John's going to take you tonight to consider some things that go from basic science knowledge into real applications, things that are relevant to clinical situations and the process of education. He has his PhD from this fine institution, the University of Montana, and he is now in the Phyllis J. Washington College of Education and Human Sciences, where he's an associate professor. And I can say I've enjoyed getting to know him a little better from being together in this series of lectures, and I think he's going to talk about some really relevant information tonight that will have probably lots of questions coming to mind. So without further ado, John.
Thank you, Chris, for that nice introduction and for picking me in, I think, a similar way that you selected Sarah to be in this series, and that is Chris did invite us to a meeting, and then suddenly we found out we were, I think, what they referred to, we were the talent, which was a little bit imposing. I'm going to start off with the lavalier mic. Hopefully it will work well. Can you hear me in the back and all around? Good. That's great. I also want to thank you for the introduction, because introductions are nice ways for us to have a little burst of serotonin, which puts me on the pathway to happiness tonight. And it's an honor to be here. I'm going to talk about that a little bit more in a moment. But I also would like to say thank you to Jay Kettering. And I don't know if Jay is in the room right now, but Jay is the point person who has organized this series of talks, and I really think that he deserves a lot of credit, and I don't know if anybody has mentioned that yet, so I wanted to say thank you to Jay. I also wanted to say thank you to my wife, Rita, who I think is hiding in the back corner. Thank you, Rita, because Rita not only helps me to select my wardrobe and have it match the PowerPoints, but she also really, for me, is an inspiration for probably most of my bright ideas. And so it's one of those things when you have a nice, healthy, loving relationship. Well, I think someone once said there is no better medicine than a healthy, loving relationship. It's, oh, yeah, that's one of my, I'm not really very good at things like this, but this was one of my efforts to animate the PowerPoints. And that wasn't Rita's. This is Jay Kettering, by the way, so everybody say thanks to Jay. I'd like to quickly look at where we've been. As you probably recall, the first week, about 4 weeks ago, Chris Comer gave us a very quick introduction to brain evolution. And after that, Richard Bridges efficiently summarized a whole huge area of molecular neuroscience. After that, Sarah Sertel helped us to understand the CNS in fruit flies. And I have to say that when I was in the audience and listening to those three presentations, every once in a while, I felt this sensation of being overwhelmed. Anybody else feel that? Okay. And so I found a cartoon that will illustrate this. This is an old cartoon. It's a Far Side cartoon. But this is how I felt once in a while. You can see the young man raising his hand is saying, "Mr. Osborne, may I be excused? My brain is full." I have a history of having an addiction to showing cartoons during presentations, but I did go to treatment, and there are only 3 cartoons. And so let's talk about where we're going. I would like to stay on the same track, and that is to engage all of our brains, to enlarge our brains in some ways, and to focus on assessing the brain and how it is related and is engaged in the psychotherapeutic process or the counseling process. I'm going to focus on defining depression at some point, fairly briefly, and then summarize some evidence-based research that is linked to some brain studies on how do we address depression in people who come for counseling or psychotherapy. So that's the plan. And I'd like to just, I guess, to bring us to some caveats and explanations. First of all, I will tell a few stories about counseling during our night. And when I tell a story, either I have permission to tell the story, or I'm disguising the identity so that the person can't be identified. In addition, I will show a couple of video clips of myself doing counseling. Very short. One's about 1 minute. The other one is about 2.5 minutes. But they're designed to give you a sense of what might happen in an actual counseling session and how we can speculate about how that might affect the brain. I also would like to warn you that this particular talk is not going to be linear. Now, my students at the University of Montana would probably say, well, of course, because John can't really stay focused for very long. Probably has something to do with his brain. And I would like to blame it on the fact, something that Sarah said last week, and that is one neuron is talking to many. And if you think about it, it's not just one neuron talking to many, it's many neurons simultaneously talking to many other neurons in a way that makes it really difficult, I think, to talk about the brain and talk about it in a simplistic and linear kind of way. And then I also would like to tell a little story about my own background. I did graduate from Oregon State University. Go Beavers. Anybody else? And then I worked at a psychiatric hospital, a 23-bed hospital in the Portland, Vancouver area. And at that hospital, my job was... Thank you, Jay. Once again, let's hear it for Jay. And so I began working at a psychiatric hospital as a recreation therapist. And my job was to take the patients to the movies and bowling and out for ice cream, and also to engage them in various recreational activities within the hospital. I often would play games that were invented. In fact, I had a friend of mine who invented the Newly Friend game, in which the psychiatric patients would pair up, try to get to know each other, and then go into a soundproof booth, and, you know, like the Newly Wed game, only the Newly Friend game, and had a great time. But there was also an opportunity for me to get to know a number of professionals from different disciplines. Psychiatry, psychology, counseling, social work, all represented there. And I remember a particular psychiatrist, whom I'll refer to as Dr. M. And Dr. M was a staunch biological psychiatrist. And I remember him telling me on a number of occasions that it won't be long, maybe 20 years in the future, when what we'll have are a set of designer drugs. And those designer drugs will do exactly what we need to have done in psychotherapy and counseling. And consequently, there will be no need for any other kind of intervention other than biogenetic interventions. And I think maybe that was his pitch to try to get me to go to medical school. But instead, I decided to come and study clinical psychology at the University of Montana. And I have to say, I am very happy I did. As it turns out, 31 years later, as you may recall from Richard Bridges' discussion of the molecular neuroscience, we still don't have specific medications that really can target exclusively specific places in the brain. And so you probably need to know that about me to know a little bit about my bias, and that although I may refer to medications once in a while tonight, the emphasis really is going to be on the human interaction and counseling or psychotherapy. And now I got distracted and I lost this, but here we go. Oh, you know, I don't know why, but I just thought to myself, we keep saying the beauty of the brain, and it is beautiful, I think, in function. But occasionally I look at this thing, and it's kind of lumpy. It's kind of asymmetric. And there are little bulges and veins. And anyway, it doesn't strike me as physically beautiful, but I think it's functionally incredible. We're going to do an activity, but I just have to do one last thing by way of introduction. It is an honor to be here, and I want to say thanks to Todd Goodrich for taking that nice poster picture of us. You may have seen it. One of my students a couple weeks ago came dashing into my office saying, John, at the snowboard shop in town here in Missoula, they've taken the poster and they've cut all of the individuals into paper dolls. And they have them pinned up. And in fact, she said, John, because your arm is sticking out, they made it so you have a movable arm. And so my arm can move back and forth. It's pretty darn cool. So she brought it to me, stole it from the snowboard shop. I know that they're probably not missing it. And then that reminded me that I happen to have a cutout of Sigmund Freud. And given how Rita feels about Sigmund Freud, I feel sometimes I'm battling Sigmund Freud off. And the thing I want to say is that you can see my arm can move, his cannot. And so I can punch like a fruit fly. Just want to say that. So let's do an activity. Everybody hold up your hands. One hand. Just one hand is fine. Either one. Doesn't matter. So you're holding up that hand, and now look at it. And look at your hand, and look at the fingerprints. And you know that if somebody became so inspired by tonight's talk that you broke into the Spectrum Museum and you stole that big brain in the poster, you know if you left fingerprints, you could be identified, right? Because your fingerprints are unique. And your iris is unique. And the retinal capillaries in the back of your eye are unique. You can be identified by any of those things. You can also be identified by your typing. You may be aware of the fact that some online universities do a 10 to 15 minute typing test at the beginning so that they can tell if you're doing an essay at the end of the semester if you're the same person. Ooh, spooky. And we also know that human gait, the way you walk, is unique as well, and that certain people can look at the way people walk and identify them. I also have a friend who's a forensic linguistic expert, and he can identify people by the way they talk, and he always says I say some things incorrectly. I've been working on my grammar ever since. But of course, the more important thing is every brain in this room. We might have 200, 250 people here, and every brain is unique. Every one. And because of that, my first really important disclaimer is that my brain is not your brain. I don't see and hear and think about things in the same way you do. And because of that, although we're talking about depression tonight, I can't say, this is what you should do, because it may work differently for you in your brain than it works for me or for other people who have been depressed. And so I'd like people to promise that you won't take my advice and go out and try it and then say, see, it didn't work. And that's one of the, I think, exciting mysteries about humans, and that we're all unique and you never really know what might help a particular individual. There's no magic bullet other than the one that Richard Bridges talked about that he shot. He said if you shoot a bullet through a television, it's kind of an analogy for how psychotropic medications work, and the television happens to start working. I love that image. Okay, now, really quickly, another activity. Smart people generally take notes, and I happen to notice that a number of you you've paid good money to be at this lecture, and here you are not taking notes. I do notice a few people in the front, and I want to say I'm really, so get everybody get out a pen. Or a pencil. Pencil would be fine. You didn't even bring one? Okay, well, now, one of the cool things about the brain is if you don't happen to have a pen or a pencil, imagine one. Okay? Imagine one. And here's what I'd like you to do. First of all, how many of you, maybe 2 or 3 people who are not shy, just shout out what you thought when I said get out pencils and pens. I know I wasn't as stern as I was supposed to be to get a reaction, but anybody, what did you think? Pop quiz. Pop quiz, and darn it, she's ready. Okay? And Ginny thought, it's a joke. It's a joke. Any third idea that went through anybody's head?
Forget it.
Forget it. Thank you. Thank you. And so, again, somebody back here,
My son already has one.
he has one out, and I'm proud of him too. And so, good work. What I was going to say is that this is also an example of your unique brain, right? We have 200 and some people, probably 200 and different kinds of reactions to that command. And yet that wasn't the real purpose of this activity. It is when you have a command or something that you're requested to do, sometimes your brain lights up a little bit. It gets engaged. It gets involved. And so I want you to do another thing. And if you have a pen, and don't do it until, well, I don't even have one. Okay, if you have a pen and you're willing, take your pen and put it in your mouth and hold it with your lips. If that makes you think about germs, then don't do that, okay? Just imagine, thank you, I have one person in the room. If you're holding it with your lips, it will affect your brain in a certain way. And if you then change, and thank you, person in the front row, and hold it with your teeth like this, now pretend you have one, a pen or a pencil in your teeth, like this, okay? Hold your teeth like this, okay? Now, while you're holding your teeth like that, I want you to begin something we in psychology refer to, and psychiatry, as serial sevens. Begin with the number 100 and start subtracting by 7. 100 minus 7, minus 7, minus 7, okay? We do this as a way to evaluate mental status. And you can stop now. The reason I'm having you do this activity is because research has shown if you hold a pen in your mouth with your lips, that you will report more down or depressive feelings. If you hold it with your teeth, you will report more positive or uplifting feelings. Now, this is not a permanent cure for depression. But the point is, it directly affects your emotional state, partly because of the feedback loop. Your brain gets the information that your face is smiling and then processes it and then comes to the conclusion that I must be happy. Okay? The second activity I had you try doing simultaneously was to do some subtraction. And of course, the purpose for that is to simultaneously light up your brain doing a different activity. The first one had to do with motor feedback, and it can cause different kinds of emotional conclusions. The second one, anybody while you were doing the serial sevens, if you really did them, and I know you guys taking notes did, if you did the serial sevens, anybody have simultaneously a thought process in the background? Thinking something like, I'm not very good at math. I didn't know he was going to make us do math. Or maybe the thought, I'm doing pretty well. I know, 93, 86, 79, I'm doing pretty well. Now the point is this is a depressed brain. And when it comes to monitoring the way that depression affects the brain, we're still in the beginning stages. But there's been some pretty good research that shows that there are differences. We see this brain not very lit up on the brain scan, not as much blood flow, not as much neural activity, okay? Not as much of the electrochemical stuff that makes brains go. Whereas this brain, in a not depressed person, has a whole lot of activity going on. The things we did were designed to make your brain wake up and light up a little bit. But in someone who might be chronically depressed, you may not see much activity, even though for most people, it sort of turns your brain on. Does that make sense? Everybody with me? And so the important thing to remember, one important thing to remember, is that there are differences between, quote, depressed brains and not depressed brains. But the other thing to remember is that it is correlational. And that many people, and I remember watching Charlie Rose a while back, and this same kind of scientific mistake was made, and that is people would say, well, depression is caused by a depressed brain. In fact, we don't know that. Depression also could be caused by depressed behaviors, right? Or a history of thinking negative thoughts, or trauma, or a number of other factors, oftentimes involving unhappy relationships, that could cause brains to become more depressed. Does that make sense? Now, it goes both ways, is the point I'm trying to make. And that when two things co-vary, it doesn't mean that one causes the other. Now, the cool thing we found out, though, is that through psychotherapy, changes in the brain can happen. And I'll show you some slides that show that in a little while. As we go through this nonlinear process, now we're going to look at that commentary. Almost all of us have in the back of our head a little voice. Some of us have a big voice that comments on our behavior. You're in a social situation. You walk into a social situation like some of those advertisings that show how anxious you should be. And you might start to think, I wonder if anybody notices that I'm sweating, right? I don't think I'll be able to think of anything cool to say at all. Oh no, I see people here I don't really feel comfortable with. I wonder if they'll notice that I'm uncomfortable. And so you begin to think a whole lot of thoughts in the back of your head. Most people do this. Aaron Beck, in the 1950s, who was one of the founders of cognitive therapy, discovered this in his patients who were doing free association. And what they were doing is they were just saying whatever came to mind. That's what free association is. It's sort of a Freudian thing. I did bring a little Freudian doll there too. Now, what he discovered is that as people were free associating, they were also thinking things like, I can't believe I'm saying this. My psychiatrist is going to think I'm stupid. I must have something more important to say. And so there would be this commentary on the free association, and what he decided is that's really the target of treatment. Okay? That's really what we need to focus on. Not so much the free association, but that commentary that's happening in the back of people's minds all the time. And so as we look at the discovery of cognitive therapy, the movement in current or contemporary therapeutic practice is to focus now on changing thinking, behavior, and relationships. And those are the primary three things that we focus on in psychotherapy or counseling. This is a quote from Freud, and I just want to read it because it speaks to why and how therapy can be powerful. Freud said, "Words were originally magic, and to this day words have retained much of their ancient magical power. By words, one person can make another blissfully happy or drive him or her to despair." Words is in part what psychotherapy entails, and I'm sure all of you have had the experience of hearing words and having particular reactions. I have a story I would tell, but we need to keep moving. And so now I'm going to show you a short video clip. This is about 1 minute. I'm working with a young man from Trapper Creek Job Corps. At Trapper Creek Job Corps, we have 16 to 24-year-olds who are seeking vocational and educational training so that they can move from more of a kind of a poverty status and hopefully be able to be gainfully employed afterwards. It's located a little bit south of Darby, a beautiful setting. Many of the students come from Colorado and from urban areas. I am working here with a young man who is a gang member in the Blood gang, and you might figure that out by the way he's dressed for the video. He was paid $20. I like to think that that wasn't why we got along pretty well, but he had a history of being very irritable and nasty and difficult to a number of people, including counselors and including Rita, who had seen him before I did. This is the second time I met with him, and what I want to show is I want you to watch. I have a spontaneous thought. I share it with him in this 1 minute clip, and watch his reaction, and then watch my reaction, and then watch this kind of interpersonal encounter that happens in the counseling session. It works better if you push the right button.
Where there's no games, and I could be focused. You know, I ain't got to worry about how much longer I'm going to live or all this other good stuff, you know. And it's actually pretty different.
So, you made a good pick.
Yeah,
You think?
yeah.
So I just had this funny image come into my mind. I'm just going to tell you what it was, okay? I just had this really funny thought that, what if you were dressed like me? You can't even imagine it, can you?
No.
I just thought to myself, what if we just like switched?
Actually, you look pretty cool with
I
this
would.
on.
You're saying you wouldn't look so good with this.
No,
Have you ever dressed like this?
no.
How do you know you wouldn't look cool then?
Because that's not my style, man.
Yeah?
No, it's not my style.
No, I'm not saying it should be.
Yeah.
In this 1 minute, right? 1 minute, there are a huge number of things going on. And even though I say to him, you can't imagine yourself dressed like me, do you think he imagined it? He had to have his neck kind of whipped back that far at the thought of being dressed in a pink shirt and khakis, right? And then you saw me reacting to him. He also gave me kind of a little compliment, right? By saying, well, I'd look pretty good dressed. I would not look good like that, you know? But what's happening is that we're building connection and we're building relationship in that moment. And then I say, have you ever dressed like that? Well, how do you know you wouldn't look cool? And what is it? Not my style. Not my style. Now, at that point, I now backpedal, right? Because I don't want to tell him that he needs to change his style. We are certainly not ready for that. And one of the tricks in counseling and psychotherapy is timing. And that is, can you imagine, and I think this is one of the reasons things didn't go well with certain people and this young man, could you imagine if I had just started off by telling him, hey man, you need to change. Let me explain to you some ways that you need to change to be successful. I actually think I could make a really good list for him, right? And how do you think he would respond? It would be very negative. It would be a very short therapy experience. And I have to say, one of the things that I have learned over the years in working with difficult or challenging teenagers, is that if you say the wrong thing, they often will say F you and walk out of the room. I've had that happen to me a number of times, and I have to say, I feel like I'm getting better at doing it. Just the other day, I was working with a young man who is incredibly irritable and difficult at Trapper Creek. I walked in, I sat down with him. He had said he wanted some help. He looks at me, he says, man, I don't want to talk to you. I don't want anything to do with talking to you. You're too. I said, well, how come? I'm just curious. You're too sketchy. And he looked at me, he goes, look at the way you're dressed. I say to him, oh, well, okay. There's no way I want to force myself on you. If you would like to talk at some point in the future, that's great. So I empower him. He leaves. In 2 weeks, he's back in my office. And now he comes to see me every week, and he gets upset if I haven't set aside a time for him to meet with me. And if I had in that first session said, no, wait a minute, buddy. You sit there and you talk to me. It would have been a disaster. He never would have come back. So let's look at depression. Depression is not the same as sadness. Most of you already know that. It involves, this is one particular type of depression called major depression. You have to have 5 of these 9 symptoms to qualify for major depression. If you're a child or adolescent, you may be irritable instead of depressed. Some of you may have noticed that in your children and adolescents, that occasionally they act irritable. But even that occasional irritability is not depression. That's normal. You have to have at least 5 symptoms. One of them has to be a depressed or irritable mood, and the other one has to be anhedonia, or the loss of feeling of pleasure in doing usually pleasurable things. So you have to have one of those 2 plus 4 more. So you have to have 5 of these. They have to go on for at least 2 weeks, and it has to significantly impair your ability to function in a social or a vocational setting, or cause you substantial distress, personal distress. That's really the definition of depression. This is the main kind of depression that's diagnosed. You can see the symptoms. They're not very pleasant, as you can see in this next slide. The bluebird of happiness long absent from his life, Ned is visited by the chicken of depression. You can see things are not going well for Ned in his life. He's probably not gotten out of his pajamas for a while. Now, one of the things I think that's important about this particular cartoon is that one thing we know about depression is if you become depressed and it goes on for a long period of time, it becomes harder for you to fully recover, and you become more susceptible to depressive episodes in the future. This fits really well with what we know about the brain, and that is the more we engage in particular behaviors over and over again, and if they're behaviors like Ned here, the more likely we will get stuck in a rut where the brain kind of shuts down, as you saw in the earlier slide of the brain. Does that making sense to you guys? So the longer it goes on, in some ways, the deeper the rut gets. And so some kind of intervention early is often recommended. But what causes what? I was just joking when I said, of course, maybe I got a little serotonin rush when Chris said nice things about me when he introduced me. The brain is not that simplistic. We do know that serotonin and norepinephrine are involved in improving mood and improving levels of activity. We know they're involved in that, and that's why the medications and the pharmaceutical companies target those neurotransmitters. But that's not all. And to think of it as simple as let's just increase our serotonin, or I just had my serotonin increased, or maybe we should put Prozac in the water, really kind of misses the point. And that is that there are many things going on at the same time. Because it may be our depressive behaviors, as I've mentioned before, negative thinking patterns that are going on, unhappy relationships, all those things can make our brains depressed. And so this is my confusion slide designed to emphasize that it is a nonlinear, multivariate causal model when we think about depression and how it comes about and how we remediate it. Which brings me to, I don't know if you're familiar with the old saying about Brazil. Brazil is the country of the future and always will be. That's what they say about Brazil. I think the Brazilians actually say that, so I hope I'm not offending any Brazilians. But anyway, I made up this because I think we're at the very beginning of understanding the human brain and always will be. And I say that partly as a joke, but also because in some ways I hope that. Because I hope that the brain stays in some ways pretty mysterious. I hope we don't get to the place where Dr. M said, where we have a designer drug that will address our issues. Not that I'm against medications, but that I think maybe we should look at the bigger picture. Several years ago, I went to a talk by the Dalai Lama. And actually, it was not the Dalai Lama talking. Rita and I went to Emory University, where he was made an honorary professor. I thought that was pretty cool. And we went to a thing on the brain. And a number of very prestigious biological psychiatrists and psychologists presented their papers to the Dalai Lama and his translator in front of a large, large group. And then the Dalai Lama would ask questions and make points, and they would interact after the presentation. One presentation that stands out in my mind for relevance to what we're talking about today was with Charles Nemiroff from Emory University, who is a very prestigious biological psychiatrist. And he was presenting on depression. And as he presented, he said, we really know now for sure that 2/3 of all depressions are caused by the environment. And we also know that 1/3 of all depressions are caused by biogenetics. And the specifics are difficult to identify, but we know that through animal studies, and he presented some animal studies and some human studies, that what appears to happen is that there is a gene that's sensitive to trauma and adverse situations. And so individuals who have that gene are almost always going to be inclined to become depressed when faced with difficult circumstances. So he gets done talking, or he's not done talking, but in the middle there's this interruption, and we can hear that there is a discussion back and forth in another language. And finally, the translator for the Dalai Lama says, Dr. Nemiroff, His Holiness is wondering if 2/3 of all depression is caused by the environment, and 1/3 of all depressions is caused by a genetic predisposition that has to be activated by trauma or a difficult life situation, then wouldn't you say that all depression is caused by human experience? Interesting question. There was a long pause, at which point Dr. Nemiroff said, yes, that would be true. I don't think it's even that simple. I'm pretty certain that there are some predispositions that are genetic that probably might cause depression even before social interaction occurs. But we do need to look at social interaction. We do need to look at the social roots of depression, because there are a number of things that are related to the development of depression that are in the social arena. Now, I have to say, I have permission to show these twins. These are my twin grandchildren. And they are clearly in this photo having a social experience. A few years ago, I was doing a talk and I invented the term tripolar disorder, which I believe children have, babies especially, because they laugh one minute, they cry the next minute, they're asleep the next minute, and if they're hungry, it's just really, really bad. Some social factors that seem to contribute to the onset of depression include, and this is pretty common sense, but it's supported by research, early caretaker infant-toddler interactions. Harsh and judgmental caretakers. Now, I put this down there. I'm not saying this is like the critical parent. What I'm saying is that this is the really, really difficult parent. And I'm going to tell a short story, and it has profanity in it, but I'm quoting someone, and so I think it's okay. I'm at a park, and I happen to overhear a father and son walk by. And I can hear the father ranting at the son, and finally he looks at him and says, like I give a shit over how you feel. This is what I mean by harsh, judgmental caretakers. I don't mean a parent that is critical or a tiger parent or whatever it is that we're calling them now. I'm saying people sometimes go beyond what's appropriate. And childhood trauma and loss very significantly contributes to the onset of a depressive process. We know from studies of the brain that children who are deprived, significantly deprived of touch, often of food, but of human social interaction, that their brains developed in much slower and deviant ways than normal children. And you can see this, you don't have to really know much more than to look at those brains to see that they are going to function much differently. But the social often leads to the psychological, okay? And so we have social experiences, and this is where it gets a little bit psychoanalytic, but I don't want to emphasize that too much. But early, almost everybody, even the cognitive behavioral therapists, agree that early social experiences build schema or beliefs, or what the attachment theorists would say is an internal working model. And this internal working model is all about expectations. It's about expectations that we sometimes build into a narrative or a story that we tell about ourselves. And usually this has three parts. A narrative or a story I tell myself about myself, a narrative or a story I tell myself about other people or the world in general, and a narrative that I tell myself about the future. And that those three dimensions often get internalized through social experiences, which is why sometimes people believe that Aaron Beck discovering that commentator in the background may have been internalized parent figures or caretaker figures that were quite harsh and difficult. Okay? And the target of cognitive behavioral therapy and most of the evidence-based therapies is squarely on these dimensions. And so let's look at another thing Aaron Beck discovered you may have heard of. It's called the negative cognitive triad. The negative cognitive triad consists of three dimensions. The first being the self. Thoughts like, I am basically defective and unlovable. You may know people who seem to have that view of themselves. The second dimension of the negative cognitive triad is other people / the world are stupid and unkind. And the third dimension has to do with the future. I'm doomed. Future orientation, forever to be disappointed by others and to be a disappointment to everyone, including myself. Okay? You could imagine that if someone is stuck with this kind of negative cognitive triad, think back to Ned in the cartoon, for a long time, and sometimes even a short time, you will see differences in brain functioning develop partly as a function of this negative thinking pattern. I just thought I'd share the adolescent version of this. The adolescent version is I suck, you suck, the world sucks, and it always will. Okay? And again, we see this kind of chronic mentality in some adolescents who are experiencing depression. This also could be formulated as learned helplessness, as it was by Martin Seligman in 1971 when he did a series of experiments with dogs and basically trapped them with electric shocks so that they couldn't leave, and pretty soon when there even was a way to leave, they didn't go for it because they had learned they were helpless and it was pointless to try to escape. It also could be related to the fruit fly loser mentality. And I just want you to know that one of the really cool things about the human brain is it's bigger and better than the fruit fly brain. And so, even though, and like if anybody's gets upset about what I'm presenting on, I just want you to know that although you could come up here and take a lunge at me, Even though I'm male, I can lunge or headbutt. Okay? I don't have those particular constraints, but the point is that these kinds of cognitions over and over again obviously cause neurochemical changes. Here's one sort of bit of evidence of that. You may be familiar with the diagnosis borderline personality disorder. Borderline personality disorder is characterized at least primarily by emotional reactivity. And so what they did in this particular experiment is they looked at brains of individuals who had borderline personality disorder, and they showed them disturbing images, and they compared them to the brains or the brain activity of individuals without borderline personality disorder. And what they found, and this is interesting and it makes perfect sense, is that in the brain, and you can see this is the right side of the brain, in particular, this area often associated with some emotional reaction. And so you see in the individuals who are diagnosed with this disorder that they in some ways have trained their brains, or maybe their brains were originally the kind of brain that reacted strongly to disturbing images. And you'll see also from looking at the bottom, you see it's not so pronounced. Looking at the bottom, you can see on the left side of the brain, in the normal individual, there's a little spot that's pretty much on fire, whereas there's not much going on here on the left side of the brain. We're looking from the bottom now, in the people with borderline personality disorder. This would suggest, one hypothesis, one theoretical perspective might be that the normal individuals, when they see disturbing images, use verbal mediation to cope with them. They talk to themselves, and that they're much more able to access the left side of the brain that's a little more language-based than the right side that's a little more emotional. Okay? Now we're going to shift toward the evidence-based approaches. And I wanted to highlight one particular psychiatrist. Her name is Frieda Fromm-Reichmann. Practiced psychiatry primarily in the early 1900s. Amazing for a woman. She also came up with a quote that I think helps to guide us in how we like to or should work with individuals who are depressed. And that is, the patient needs an experience, not an explanation. We can tell people what to do. We can tell them what's wrong. We can explain things to them. But if they don't have some sort of experience, it can even be an inner experience, then we're probably not helping them in the long run. This is one of my favorite overheads. I'm sorry, the writing's bad, but I'm going to read it to you, so don't worry. Here we can see that Calvin is offering an experience. A swift kick in the butt for only $1. Hobbes walks up and says, "How's business?" Calvin says, "Terrible." Hobbes says, "Oh, that's hard to believe." Calvin says, "I can't understand it. Everybody I know needs what I'm selling." So that's an experience a lot of people did not want to pay for good reason. Now, one thing that we haven't mentioned yet, but that also has a powerful influence on positive outcomes in depression, is what we refer to as the placebo effect. Sometimes terms that are also used to describe this include hope, faith, expectation, and often it involves some kind of ritual. In 1987, a Dutch researcher, psychiatrist, did the first ever double-blind, placebo-controlled study with children or adolescents. There had been none done before that. A double-blind, placebo-controlled study would mean that you take half of the people, well, you take all the people, I'm sorry, and you diagnose them. And he took a 2-week period to repeatedly administer diagnostic batteries to these children. Average age was 9. Then he randomly assigned 22 to the imipramine group. That's an old antidepressant, a tricyclic antidepressant. And he assigned 20 kids to the placebo group. But the kids didn't know what they were getting. The parents didn't know what they were getting. And the psychiatrist who was administering the medications didn't know what the kids were getting. Okay? Only the person who designed the formulary knew what was in the pills, either imipramine or an inert placebo, sometimes referred to as a sugar pill. What he found was, and this is a remarkable number, 45% of the children were vastly improved in only 5 weeks. Okay? 5 weeks. That was the length of the study. And I don't have the numbers for the placebo group because I kind of wanted you to think about it. But in the placebo group, 69% were substantially recovered. It turns out that there never was a study with children or adolescents that showed that the tricyclic antidepressants were more effective than placebo. This is not to dismiss the efficacy of the old tricyclics, or certainly the new SSRIs, which have fared quite a bit better. But what it's supposed to say is that something was going on in this study where whoever was meeting with those kids was giving them hope, and the pill was giving them expectation, and the outcome was remarkably positive. The point is not that antidepressants are ineffective, but that the placebo response when it comes to child and adolescent depression is really hard to beat. Okay? Really hard to beat. Hope is, in many ways, an antidepressant. Now I want to show another short clip. This one's about 2 minutes. I'm now going to be working using what we might broadly call an evidence-based approach to help a young woman who says that her primary problem is anger, irritability, and she wants some assistance with this. And what I've done is I've already set the goal with her collaboratively that she's going to work on anger. And now we're talking about, and now I do a technique that's referred to as the affect bridge, originally invented actually by Dr. Jack Watkins from the University of Montana.
So tell me, I'm gonna ask you some questions about the anger stuff. When is the first time, how old were you when you felt like, I got this temper, or somebody told you, you got a temper?
Well, I have short-term memory, so I'm going to try really, I sometimes just can't remember that far. It's probably like 3rd grade.
Okay.
Well, no, it was like 3rd grade, I beat up my sister.
Older, younger sister?
Older.
Okay. You beat her up?
Because she tried to beat me up, so I jumped on her stomach a few times. I felt really bad, though. Like, I cried for days in my sleep, because I felt really bad. I kept apologizing to her, apologizing. Like, it'd come up to me, a few months later, and be like, actually, I'm so sorry about what happened that one time. She'd be like, oh, it's okay. Or just go off and be like, that was dumb, but it's okay.
Yeah, yeah. So that's an example of pretty early.
Yeah, that I can remember. But, I bet if I had more time, I'd probably...
Go back even before.
Even before. Oh, wait. Once, when I was 4, my brother and sister used to play keep away from Megan, and they'd run away from me and jump fences. I was 4 years old. I couldn't,
You're both older than you?
Yeah, I'm the youngest. I couldn't chase after them. I couldn't jump a fence. I was 4, and it made me angry. That one and the other one, if I can think of.
So when you say that second one, you sound sad.
Yeah, it made me sad, too.
Yeah.
I think more angry.
Sure.
I was really young, though. The one that, really comes to my mind that I was very angry was the first one. Just because.
In 3rd grade? Or
Yeah, 3rd grade.
Your sister was trying to beat you up.
She was trying to, embarrass me, and make me look like I was nothing because she had older friends or something like that. Like, make me look stupid in front of my friends.
Okay.
So that made me very peeled. And I chased her around the, schoolyard and cornered her and started jumping on her stomach. Everybody's like, oh, going on, like cheering me on. And then we sat at the corner of the school, and yeah, I got in trouble.
Yeah.
Yeah, I still think about that.
And so first, the early one, when you were 4, kind of made you sad and mad.
Yeah.
And the second one, it sounds like it made you embarrassed and mad.
Yeah, I was embarrassed of what I did. That's the word. Yeah, that's exactly how I felt because I didn't, want people to think, I just hated my sister, which I kind of do.
But you were embarrassed, though. She tried to embarrass you,
Yeah.
I would say. So embarrassed, and then mad, and then embarrassed.
And then embarrassed that I did it.
Right.
So I was feeling two, types of embarrassment.
On both
yeah.
ends
Yeah.
of the mad.
Mm-hmm.
Okay.
It didn't level very well.
So Megan, also from Trapper Creek, and again, thanks to Trapper Creek and thanks to her for being willing to be filmed. What's going on in this is we're reflecting on memories that are unpleasant. Now, you could do this with painful memories, you can do it with unpleasant memories, but you'll notice that what happens is I ask her about an early time when she felt angry. That's the affect bridge, right? Anger in the present to anger in the past. I don't have, excuse me, I took a drink and now I'm really in trouble. I don't have a really good neuroscience to support the fact that, and I think Chris Comer does, and that's why I'm looking at him, that when you go back and forth to a memory, it seems to go right down an affective path, right? Because she, even though she says she has short-term memory, she finds a memory really quick, right? Then she finds a second memory. And so it seems like there's a little river of affect that we can use to kind of tie these things together. And one of the goals of this kind of therapy is to reflect on the memories, to deconstruct them and to reconstruct them. And what I mean by that is we look at the memory and we try to find things about her and her behavior that may have been positive, that might be reflective of a more positive identity in her. And then we might also help her develop greater self-control over being controlled by old ideas from the past. Many times people come in for counseling because the past is leaking into the present, right, and causing future behaviors. And so by doing this kind of a process, we can help her to rebuild and shuffle and change the way her memories affect her in the present. Now, another evidence-based strategy that actually has some brain scan data to support it is exposure and response prevention. This is used across a number of different disorders, including trauma and obsessive-compulsive disorder. It's relevant to depression because oftentimes individuals with those disorders are very depressed as well because of the limitations associated with that. What happens is we actively expose clients to fearful and distressing or depressing triggers, but it's based on the theory that we can't have two simultaneous feelings. The original study, 1924, really new stuff, Mary Cover Jones, took fearful children who had developed a fear of white rats, put the white rats back in the corner of the room by Rita, had the kids eat cookies, and then progressively, over time, brought the white rat all the way to the kid's lap. It's called counter-conditioning, sometimes systematic desensitization. Now we refer to it as exposure and response prevention. What happens is that people learn that it's now safe to face those fears. Again, although it's a really fun story, we're going to miss it. Here's an example of evidence that therapy can change the brain in as few as 4 sessions. Now, I don't want to say that we should limit people to 4 sessions because, in fact, the research suggests that to help 50% of the people, you need 20 to 25 sessions as the average, which is where, of course, managed care is now, right? Sorry, that was sarcastic. You can see that there is more activity before the therapy and the exposure in the limbic system or the caudate nucleus than there is after experiencing exposure. And this is actually a technique that's sometimes used as self-help. People can actually use a book to help them get over their OCD, or obsessive-compulsive disorder. And here are some of the brain structures that appear to be involved in, deep in the brain, in emotions and anxiety, and that seem to be going off in a sort of a fire alarm kind of a way for people who have phobias or obsessive-compulsive disorder, so that when they see a particular stimulus, they've got a little fire alarm going off and they respond. And as you know, OCD people respond often by engaging in repetitive behaviors designed to reduce their anxiety. It appears that exposure and response prevention will help to decrease the reactivity of that particular structure in the brain. But again, I don't want to paint this too simplistically. There is probably much more than just that going on. Another evidence-based approach is behavioral activation. Behavioral activation involving exercise, obviously, but any kind of exercise. Weightlifting, yoga, intensive cardio or aerobic activity, all seem to have positive antidepressant effects. Pleasant event scheduling, just getting out and doing things that you used to think were pleasant. Even though you're depressed, doing those things that you used to think were pleasant and getting engaged in them seems to have an antidepressant effect. Sometimes in therapy, one of the things we tell people who say, well, I don't know, that just doesn't sound fun anymore. We tell them, well, you know, that's the depression talking. That's the depression telling you it's not fun. Go do it anyway. Go do it anyway. Give yourself a chance to be exposed to positive and pleasant events. Therapeutic massage tends to make people feel, it does work for me, personally. And then I want to tell you a quick story about a young man I saw. He was about 25. He was really very depressed. He had a history of abusing substances, alcohol. He'd managed to recover or be in recovery for that. And then he came to see me, wasn't leaving the house, wasn't going to school, wasn't doing anything. Very much consumed by the negative cognitive triad. I remember one time, maybe after 6 or 8 sessions, I saw him in the waiting room. He was actually chatting with another therapist who was in the office. He came back to my office. I said to him, hey, you know, one thing I've noticed about you from time to time is that you just have really good social skills. You know how to just chit-chat and have a conversation with people. You know, he kind of looked at me. I thought I was saying something really important, giving him feedback. He just kind of looked at me. A few more sessions go by. I give him an assignment called a sparkling moment assignment, meaning that oftentimes people who are depressed, they're looking for the gloomy times. That's what they're tracking, right? And they notice it. It confirms their ideas about the world sucks and everything else, and I do. And so I said, just look for and write down any sparkling moments that you experience, and that's all. Try to ignore all the bad ones. Just focus on the sparkling moments. And I gave him a behavior activation assignment, do something. And he signed up to go on, I think it was a rattlesnake hike, maybe associated with the outdoor thing here on campus. And anyway, he ends up on a hike with a group. And you can guess what happens. He has a pretty good time. And he meets a young woman. And he likes her. And she appears to like him. And then the next time he comes to see me, he's really happy. And he tells me this story. He says, you know, I went on this hike. It was great. But then I got home. And when I was at home, I was frozen. I mean, I hadn't called anybody to really do anything for months. And the thought of calling her and maybe she wouldn't recognize me. You guys know, we've all been in that kind of romantic situation, right? Where you want to call somebody you're interested in. The anxiety's high. It was just punishing and painful for him. And he said, but you know, I was there on my couch for maybe a couple hours with my phone, and finally I remembered that you said, I have good social skills. And so I thought to myself, in that moment when I had that thought, I dialed it up, and I got her, and she remembered me, and she wanted to get together, and then now, she's my girlfriend. Very happy kid, very happy outcome. What it illustrates is behavioral activation, but it also illustrates some cognitive restructuring. Again, the kinds of things that we do to get the brain kick-started or shifted from the depressed brain into a more active and positive brain. And that means using what we call collaborative empiricism to challenge and change the negative cognitive triad, using thought stopping, disputing negative thoughts, And this is a really interesting thing. There's an old guy named, well, he's the late Albert Ellis. He used to tell people really nasty things. Like they would say, oh, but if this person doesn't approve of my behavior, he would just go off on him. He'd say, what the holy, and he'd swear at him. I saw him at a number of conferences. He always used the F word. He always sang at the conferences. Terrible voice. Horrible, abrasive guy. He said, what we need to do is we need to dispute these negative thoughts. We need to eradicate them, basically. Well, it turns out that some people like that, and they respond well. But some people hate it. It's like if you said a negative thought to me in counseling and I said, what are you thinking? Stop thinking that. You're completely screwing yourself up, right? Now, what happens is then some people start to think, oh no, wait, I'm not supposed to think that. And then they start to feel bad about themselves because they couldn't stop themselves from thinking the negative thoughts that they were supposed to stop themselves from thinking, right? And so it can actually make people feel worse. And so another evidence-based strategy is mindfulness meditation. Mindfulness meditation involving accepting the thoughts. Oh, here, I had a negative thought. Ooh, I just gave it some wings and I let it fly away. And meditating, as it turns out, the research study was on compassionate or loving kindness meditation, but meditation, it turns out, was associated, and I don't want to get into cause and effect here, but was associated with a thicker, significantly thicker insula. And the insula is involved in a wide variety of different activities, including, not surprisingly, heart rate, blood pressure, but also cravings, as you can see up there, and kind of emotional calmness. And so there's been a fair amount of emphasis in some of the newer therapies that we need to have this sort of Buddhist mindfulness component in case people don't like to dispute their thoughts. And now we're heading down the home stretch. The Amazing Brain Revisited. The brain is beautiful and amazing in that right now you can think about how your seats feel in the chair. But if I also say, think about your feet, you can shift your awareness to your feet. You can also shift your awareness if I say, think about what you want to be doing in 5 years. You can imagine that. If I say, think about an early memory, you can imagine that. We have this incredible ability to flexibly shift our attention from the past to the present, to our body, to our thoughts. What I have come to wonder is, does it really help us to know that increasing serotonin at the synapse will help us feel better? Or does it help us to know that we are, with exposure treatment, adjusting the false alarms in the caudate nucleus? Okay? Does that help us to know that? And I've kind of puzzled over that, and I've come to the conclusion that yes, it's really helpful, but maybe not for the reason that we often think. Alfred Adler, another famous psychiatrist from a long time ago, said the whole point of insight and awareness is motivation. And I think it's probably true that knowing we can actively work on improving our brain function is immensely motivating and helpful. If we can say to people, and I said this to a group of Trapper Creek kids last week, you are working on your brains. You're jump-starting them. I know some of you have used a lot of drugs and alcohol, and maybe you've caused some derailment in your brain, but right now, today, we're doing a retreat, and you are going to get your brain stimulated, and it will help you in the future. I think knowing that we're doing that is really a helpful thing. In conclusions, we all have different brains. Some of us will respond better to cognitive therapy. Some of us will respond better to medications. Some of us will respond better to the kind of therapy that involves a little reflection into the past. Others will function better if we do behavioral activation and exercise. The cool thing is we can use many different dimensions to modify our brain in psychotherapy and out of psychotherapy. We can intentionally do things. We'll talk more about that in a couple of weeks Next week, we'll be talking about the intuitive brain. That, to me, is super exciting, and I can't wait to listen to Ashby. And I thought I would just finish with one last picture. Because one of the things we oftentimes don't focus on is the healthy and health-building quality of positive human relationships. And so with that, I'd like to say thank you for listening, and I'm happy to take some questions. You guys probably all know the MO now. I think there will be some microphones passed around.
Just raise your hand if you have a question.
There's one up there in the corner, and one there, and one here.
When you tell the kids, the young people at Trapper, about neuroscience, do they say, gee whiz? Do they say baloney, or do they just say nothing? What is their reaction?
Yeah, that's a great question. And one of the reasons I've started telling them about that is that often they will come to Trapper Creek kind of coming off of really bad drug experiences or alcohol abuse. And so a lot of them say, I'm afraid I wrecked my brain. But the good news that I try to share with them is that, yeah, maybe you did some things to your brain that weren't very good for it, but how many of us know people who came back at age 50 to college at the University of Montana, and Melanie's saying, yeah, you see some of them, right? And maybe they went through a period where their brains weren't working very well. And so I've actually found them asking about it, and they're not all interested. Many times they're not interested in anything I say. But I do find that it gives them hope to know that they can work on their brains in positive ways, as well as the negative ones that they've already generally done. Just had a girl the other day talk about how she had some brain damage, and she has a reading problem related to that, and she wondered, can I ever change? Will this reading intervention that we're doing at the University of Montana really change my brain? The answer is, we don't know, but let's throw yourself at it, and then we'll see.
In those double-blind placebo trials, does that placebo response hold up if you afterwards, if you tell the placebo group that they weren't taking the medication?
That's a great question. The question is, if you didn't hear it, in the placebo-controlled double-blind study, in the placebo group, is it maintained even after you tell them that they're just taking a placebo? Okay? Oftentimes, over time, the placebo effect in the antidepressant medication studies will deteriorate. Oftentimes, the medication effect will deteriorate. Knowing that they were just taking placebo tends to make it deteriorate more quickly. However, my wife Rita just pointed out a recent study to me the other day. Had to do with, what was it, Rita? A chronic irritable bowel syndrome, where they told the people that they were just getting a placebo, and for many of them, the effect was still maintained. Amazing, right? Amazing. Amazing. The brain, there have been studies of the placebo effects on the brain, and I don't want to get into trying to identify the different brain structures, but I would say the placebo effect has a distinct effect on the brain, and there has been some research that looked at sometimes the placebo effect and the medication effects are different. Sometimes they seem to be similar. Hard to predict.
Would you talk about the benefits of humor and laughter and how that affects the brain when someone has depression?
When we are able to produce, and one of the things, and I'm aware that there's a esteemed psychiatrist here, and as well as a pediatrician, or a couple of them I think I've seen. And so I want to say that one type of depression shows up as lack of emotional reactivity. That's one of the symptoms that we'll see that's distinct in some people who are depressed. It's like flat affect, no response to things that generally are humorous. I don't know the specific studies, but my hypothesis would be if we can somehow initiate an emotional reactivity, and with individuals like that, a medication might be the way to get them to start to have an emotional reaction with that very severe depression. But I really don't know the specific research, but my guess that I would venture is yes, the more we can get people to laugh and respond and have emotional variability and texture in their lives, the more we're helping the brain recover from a depressive episode. I know that's very general.
Well, you used laughter and humor in your example with the boy in red.
Right, right.
And it was very funny.
Yeah, and I tend to do that. That's one of the things I like to do. It helps me feel good, and I think it helps me engage with clients. But I also recognize that there's some clients who, they don't really like much humor, and so I try to be careful and respectful of where they're at. And that's another really important kind of evidence-based principle, is that we need to respect where clients are, including gender and cultural differences, which if you don't respect those things, again, you go downhill really quickly. And then what you do is you provide the individual with another disappointment experience, which I think adds to depression rather than taking it away.
Do the students at the Trapper Creek Job Corps Center, do they come to you because they've been asked or told to by the management?
Yeah, it's a good question. Do the Trapper Creek kids come voluntarily, or are they asked to? They're all voluntary. Job Corps nationally is a program that came from Lyndon Johnson's War on Poverty. So the main criterion is poverty, and they have to also deal with a fair amount of government paperwork. Warren would probably agree, who's sitting there and has worked at Trapper for 30-ish years. So they come voluntarily. They want to turn their lives around. Oftentimes they get to Trapper Creek or other Job Corps and they just want to turn around and go home, because it's quite different than the lives that they were living before they came. I got to say, let me put a pitch in, I think Job Corps are amazingly positive resources. If you think about the dropout rate in Missoula County high schools, to give kids an alternative, the kids that are more hands-on learners who really like to do stuff like weld or carpentry and office administration, I mean, really good stuff that kids have an opportunity for. They don't always take advantage of it. The system doesn't always work perfectly, but it is, in principle, a really great program.
Do you have a feel for the success rate of your program?
At Trapper Creek? Yeah. I have a feel for it, and I do know a little bit of the data, and unfortunately, we only have about 30% of the kids who enroll who actually successfully complete some component of the program. That's hard, and it's one of those things like the human brain, it's multifactorial. There are many factors that contribute to them having trouble, not the least of which many of them are 50% or more are incredibly involved with drugs and alcohol upon entry. Yeah. You want to just yell it out?
Yeah. Do you have time to tell one of your stories?
Okay. Mic for the camera. Hang on a second.
I think now you have time to tell one of the stories you didn't tell us during the presentation.
I can tell one pretty quickly, I think. I was working in Richland, Washington, also known as the home of the bombers. And I was a psychologist. It was my first year as a psychologist. And I was asked to do a pre-retirement presentation to about 150 individuals who were retiring. I was about 30 years old. I was really nervous. And I know before I talk, I just don't eat, right? Because it's a bad thing for me to eat before I talk. I've been fasting for several days, actually, now. So I didn't eat. I ended up doing the talk. It went all right. The person who asked me to do the talk put a beautiful bowl of cherries on my desk. And I get back. It's probably 2 o'clock. I'm starving. And I see those cherries, and I start popping them in my mouth. And they are delicious. And then I probably eat 10, 15 cherries, and I pick up another one, and it doesn't look very good. And then I notice there are leaves and I think, oh, somebody got this off a tree. Not that cherries don't come off of trees, but somebody got it off a tree in their backyard probably. And so I think to myself, there could be worms in these cherries. But I'm a scientist, so I break the cherry open, and I look, and there are 2 of those little maggoty worms crawling around. And I start feeling sick. But then I stop myself. I say, wait, the cherries I was eating, they were looking good. I broke open a bad-looking cherry. So I break open a good-looking cherry. Sure enough, those 2 little maggots are smaller, but they're crawling around in there. Now I'm totally sick. I'm just like hunched over, and I'm thinking, how can I... There's that little voice in your mind, you know, that we talked about it before. How can you be so stupid? That's the usual thing mine asks me. How can you be so stupid? I know I'm not stupid, but it still asks me that. And anyway. So I'm sitting there, I'm feeling terrible. A friend of mine, another psychologist, walks by, and he's solution focused. And I don't want to get into that, but it's just sort of superficial. Anyway, so he walks by, he says, hey, John, you look terrible. And I tell him what happened, and he says, whoa. He goes, oh, no, John. He goes, those worms, they could be lodged in your brain by now. Solution-focused therapy, empathy, sometimes they don't really go together. And so then he says to me, he says, no, really, wait, no, so seriously now, you should be happy because, you know, those worms, they're high in protein, they're low in fat, and they're actually a delicacy in many countries. At which point I say, get out of my office and leave me alone. And so he leaves, and it's like, it started working on my brain. I started thinking, oh yeah, when I was a kid, I ate a bunch of wormy cherries. My parents would always say, get out of the backyard. Our neighbors, they're just all wormy cherries, and I'd eat them. I never got sick. And so I started thinking to myself, and I started feeling better. And so the moral of the story is, it's not what happens to us. This is cognitive therapy. It's not what happens to us that makes us miserable, physically and emotionally. It's what we think about what happens to us that makes us miserable. Now, I didn't eat any more cherries, but I felt better.
I had a quick question. You made a mention of relationship between genes and depression. Is that relationship there? Is it pretty well established, or is it still sort of hypothetical?
That is such a good question that I'm just going to ask Chris Comer to answer. Here's what I would say based on my knowledge, sort of general knowledge about this one specific area, and that is, it does appear that what Charles Nemiroff said to the Dalai Lama holds to some extent, and that is about 1/3 of all depressions appear to have a little bit more of a biogenetic origin, and about 2/3 of them seem to have more of an environmental origin. What I think we'll find in the future is that the more severe the depression, the more likely we are to see specific genetic pathways. Okay? I don't really think the research is there based on what I've seen, and that the hypotheses right now are fairly general about that. Richard, you may have thoughts?
I think it's just what you had said, where there is evidence of a genetic component come more from inheritance studies than from identifying specific genes. So
Okay, right, exactly.
If you have one parent that has had major depression, there's can be an increased likelihood that the children will. If you have two parents, that the odds go up.
And that's exactly, I was going to look up the heritability index of depression for this talk, but because I've been fasting for several days, I forgot to do that. Because I remember thinking to myself, I want the heritability index because, as Richard is saying, the more genetic predisposition, the higher the likelihood of depression in individuals. Okay? And Blaze.
Do we know the difference between transgenerational risk and genetics? Because you've got an environmental factor there which has to be taken into account.
Right, and what we have are sometimes shared and non-shared environmental factors and shared genetic factors. And some of the best studies try to parcel those things out. As Blaze is suggesting, it's difficult because oftentimes the family environment, if you have two people who are suffering from depression, the family environment tends to be more depressive or depressogenic. And there tends to be more of a biological or genetic predisposition as well. And sorting those things out, I think, has proven very challenging. And people get in heated arguments about it. My best guidance on the question would be there are likely both of those things contributing to depressive processes, but we haven't sorted out the details yet.
Folks, we're out of time, so again, thanks to John Sommers-Flanagan.